No, you cannot actually change the structure of your fascia from foam rolling, from body tempering, from any of that. That's absurd. You would literally have to go in and cut the fascia to change the structure if you wanted to change the actual structure of it. Either that or do something that is actually beneficial and do some weightlifting and load it.
Team, welcome back to part two of the Mops and Mo's podcast, Injury Prevention FAQ. Two guests tonight. Alex, welcome back to the
Still not
show.
a guest.
John, it's good to have you again.
Hello again.
Drew acts like he runs this podcast just because he's the one with the Zoom account. It's like the
That's
only
it.
thing he brings to the table here.
Team, quick disclaimer. We ordered John a nicer microphone and it's not here yet. So he sounds just as bad as he did last time.
But I want to hear in the comments if it's actually going to be better when I use the new microphone
Yes, it will.
versus the MacBook.
Yes, it will be better.
Yeah, so frequent listeners, take a moment as he's speaking. Make sure you can experience the low quality audio he's producing right now so that you can compare it next time he appears with
Yes.
some Mops and Mo's furnished
Sometimes
equipment.
lo-fi is better.
When is lo-fi better when it comes to podcast?
Let me get back to you on that one. It's good. Good point.
So I guess admin context, last time we mentioned at the tail end of last time's episode that we had more to follow, correct?
Yep. Yeah, we
Yeah.
kind of just called it. We'd been talking for an hour. We had
Called
not
it
gotten
after
through
an
all the
hour.
notes.
Mhm.
Yeah.
So the intent of today is a continuation of the questions collected last time. And you guys just want to kick it off?
Good.
Well, I think we should clean up some kind of unfinished business from part one, which was John and I were going back and forth a little bit on ACL healing stuff. John talked about copers, which are folks who, without an ACL, can still perform just fine. Sometimes that's older folks who aren't doing a lot of pivoting athletic kind of stuff, and it's not that relevant. Sometimes it's athletes who just have strong enough support structures in their knees that they can perform without it. But there's some relatively recent research on folks who, rather than coping, experience spontaneous ACL healing. I will be honest, I Googled, I found a bunch of references, but I did not deep dive any of those references. I just kind of handed them to John as the injury and rehab expert here. John, I'm curious what you found in some of that literature.
Yeah, sure. We can split it up into some good news and some bad news. So start with good news. First of all, literature has a range of about 14 to 30% of spontaneous healing that actually can occur if you do have a complete rupture of the ACL. It's pretty cool.
Up to 30% of ruptured ACLs can spontaneously heal.
According to the studies that were conducted. Yeah.
Wow.
And then 63 to 94% of those people who have spontaneous healing reach the criteria for treatment success in the specific outcome measure that they use, which is a subjective measure. So for general populations, this is a potential new wave of a treatment opportunity. Could be an addendum to a delayed ACL reconstruction where you wait a few months, you get another picture, and then you see how you are doing functionally, and then see what the picture says as well, to potentially not go forth with the ACL reconstruction. Unfortunately, there are a lot of bads. There is not a lot of high quality evidence. It's still pretty new evidence, but that's okay. There is lacking evidence on what type of tear may lead to better results. There is some maybe grassroots research.
When I first glanced at it, that was one of the things I noticed is they don't really have any ability to predict who is going to have that spontaneous healing happen.
Mm-hmm.
They just don't know what factors contribute to it yet. That was interesting.
There's theories. Like one study looked at proximal tears being more likely to heal than distal tears, for example. And even though I said that they did reach treatment success within the outcome measure, the outcome measures that they used within the studies that showed improvements are not the ones that are used internationally to actually validate return to sport. Things like hop test, the wide balance test, other limb symmetry tests, for example, for specific to the ACL. So it's hard to generalize there. And then studies also haven't been performed on elite athletes or tactical athletes. So it's, again, difficult to generalize. So, I mean, at the end of all that, it's really neat research. It could be another conversation for if you have an ACL tear, good conversation for you to have with your surgeon. But I think for most tactical athletes, what you got to figure out first is if you're a coper or a non-coper. And if you're a coper, then you can potentially do the delayed ACLR or just avoid it altogether, and then get another picture down the road to see if that ACL has healed.
All right. Seems fair. My only question is how long did it take before early signs of spontaneous healing? Like how long do you have to wait to know whether that's going to affect you?
I believe the research ranged anywhere from 6 to 24 months. A lot of the
Ooh.
follow-ups were doing repeats. There was one study that did 13. There was one that did a 2-year follow-up and one that did a 5-year follow-up as well.
So you got to wait a pretty long time before you know whether spontaneous healing might happen for you.
You could potentially do 6 months. You may even be able to do 3. If you got a good, PCM who's going to order another image for you, why not?
It's fair. As somebody who's been through ACL reconstruction, I'll say I would have been willing to wait a few months. Like you're not completely crippled between tearing your ACL and the surgery. You might not be playing pickup basketball and stuff, but like you can still train and get around. And given that most of my longer term issues coming off of that surgery had more to do with the surgery than the ACL, like the graft site coming from patella tendon and stuff, I'd be willing to wait a little bit and see if I could heal without a surgery and a graft. So
Yeah,
pretty
not
cool.
everybody has to be Adrian Peterson and get their surgery within a week.
Yeah. Cool.
It'd be kind of nice to be Adrian Peterson, though.
I would love
Sure
to
would be
be
nice.
Adrian Peterson.
Saquon Barkley. Um, is that are we done with ACL stuff?
I think that covers the outstanding homework from last time.
Good deal. Um, okay. Let's move to low back pain. And there's a lot of content here. So where do you want to start with low back pain?
Well, I'll provide context. There's a lot of content here because me being like just living a cool, exciting
I
life
was going to
as
say
I
let's
do.
let's unpack that text from earlier.
Yeah. So I like as any normal person does, spent a
Sure.
large portion of my Sunday morning reading non-specific lower back pain exercise intervention research.
I thought you were skiing.
I also skied today. Yeah. Um,
Okay.
I was waiting for the sun to like be all the way up. So,
Why not dive into some
actually
research?
Colorado flex. I was skiing 5 minutes from my house. So instead of having to like drive to the mountains, I was literally skiing right down the road. That's pretty cool. If you're into like outdoor winter stuff or mountain stuff in general, go follow Tactical Alpinism. Might end up talking about it over on his podcast later. But I bought a pair of backcountry skis and bindings from him. Finally learning to backcountry ski a little bit. Anyway, while I was waiting for the sun to come up so I could go play in the woods, I was reading all that exercise stuff for low back pain. And like where I started from, why was I reading all this stuff on a Sunday morning? When people approach lower back pain, you always hear about like, oh, you have a weak core, you got to train your core. And I'll hand this over to John as the expert here, but as far as I can tell, there's a large body of like single intervention studies looking at like does Pilates work, does core exercise work, does functional training work, does whatever work. And the short answer is yes. If you study an intervention compared to not exercising, it's going to work. But the thing is, they all kind of work, and it doesn't really seem to matter much when you start to compare them. It seems like basically any exercise works. So I'm curious to hand it over to an actual expert here. What's going on here?
I'm glad that you asked, Alex. This is one of those things that people love to add nuance where nuance is not needed. In regards to the research, 2021, Cochrane did a systematic review that looked at exercise for low back pain. And in regards to systematic reviews, being in Cochrane is probably some of the highest quality that you can reach. So generally, we can take from that and be like, all right, this is essentially gospel in regards to exercise for chronic low back pain, according to this article. They found that it didn't matter the type of exercise. And if there was one compared to the next, they were small and not clinically relevant to be more beneficial. And that's comparing things like general exercise, core training, McGill Big Three, McKenzie exercise, all these different things where the subject matter experts in each of these fields claim that this is the way. But unfortunately, when you combine the research, that's just not how it works. They also found that there's a difference between exercise and manual therapy was also negligible for chronic low back pain, which is another interesting thing too, that exercise may not have been the panacea that some people claim it to be for low back pain. And that's similar to acute low back pain too. Certainly different for other injuries. We don't have to go down that road, but um, hopefully that answers the question. But what does that mean for people who have low back pain, which is a huge proportion? It certainly does not mean to not exercise. It just means to have a greater appreciation for general aerobic exercise and conditioning, overall fitness, and then also being able to identify specific impairments with your physical therapist, your athletic trainer, whatever have you, to maybe be able to address pain that way versus just thinking this specific exercise is your core is not firing this way or your glutes aren't firing this way. That's why you have low back pain. There's no research to suggest, or very little research to suggest that's actually what's happening.
It also, just a key takeaway I'll throw into, I read a little bit on like patient perceptions and like what they think works and what they're afraid of and all that stuff. A lot of patients are afraid of certain things as they go through lower back pain exercise. They think that like quote unquote rehab exercises are safer, McGill Big Three kind of stuff. An interesting study had like patients compare what they thought going through like dead bugs as option one, deadlifts as option two, and Jefferson curl as option three. And like everybody believes that dead bugs are safe and effective. It's like 50-50 on whether they think deadlifts are safe and effective. And a lot of people think Jefferson curls are scary and going to make them worse. And it just doesn't play out that way. Like they're all fine.
I mean, there's certainly a whole host of providers that would lead you to believe that because you might be trying to avoid certain ranges of motion that would otherwise cause pain. Now, that can be indicated in some patients, but generally, I mean, I love Jefferson curls. I think they are super beneficial if you do it controlled
Mhm.
and also slow and lightweight. People generally don't get worse from it. They often feel better. And there's no other way, or there's not many good ways to train those specific muscles throughout that range of motion. I do like kind of the knees over toes guy and some of the stuff that those
That dude's caught a
people
lot of flack.
he has caught a lot of flack. That's true. However, there is a time and a place for his exercise. And I like the way that he pushes the envelope against traditional rehab exercises, specifically for military populations, because they're probably a lot of them are tired of just doing the big three or maybe a little core exercise here and there. Maybe they want to be able to strengthen their core in extremes of range of motion to help them do better in their job in a tactical sense or on the ACFT.
I'll I'll throw out, nobody asked for it, but I'll throw out my brief opinion on knees over toes guy, aka Ben Patrick is his real name. I like that he has made people less afraid of certain ranges. I what I don't like is him pretending that like his top three exercises are like the perfect exercises for everybody that will unlock elite levels of athleticism. That said, once you realize that he's deeply, deeply involved in Scientology, a lot of things
Yeah.
start to make more sense.
Mm.
Also, as somebody who like works in a gym, I'm not responsible for any like equipment in the gym at the moment, other than like a very small selection. I would be really mad if I was a gym owner and people were forcibly walking backwards on turned off treadmills, following Ben Patrick's advice.
Yeah.
Um, they're not built for that. It's not good. Like there's other like reverse sled drags, guys. It's fine. Don't force your treadmill to go backwards.
Yeah, it's pretty sad that we have to deal with someone so insufferable to get people to do sissy squats, which is such
Yeah.
a great exercise. But
Yeah.
Two questions on low back pain. One broad and one more specific. The specific one has to do with a narrative I hear a lot, which is your glutes aren't firing. I kind of am of the opinion that your glutes have to fire, otherwise you would fall over. But walk me through that.
can you
Can a muscle
provide a
not
little bit?
fire? Like if I'm doing, let's say a deadlift, like the narrative you hear oftentimes is like, oh, my low back hurts when I do deadlifts. And then you might hear a provider say, oh, well, your glutes aren't firing. It's like, whoa, really?
I think the glutes are certainly firing if you're doing a deadlift, but the patient may tell you that they are not feeling it in their glutes. Now, there certainly could be ways that you can address that, especially if there's pain in the lower back. One of the other things that I think is more important, though, is when you get to doing a heavy deadlift, generally some of the patterns that you've learned over years and years of training, those are the ones you're going to resort to, which may mean that you are asking your low back to do a lot of the heavy lifting once you get to those higher RPEs and the higher weight versus being able to do the perfect deadlift, if you will, with all your muscles contracting. Your body's generally going to try and waste the least amount of energy by using what it has as the strongest. Where it becomes a problem is, say someone does a deadlift and they say, I can feel the left side of my glutes working, but not the right side. What's going on with that? That is where we have to come in, and then maybe we address what's going on um, in like a asymmetrical point of view.
Second question, a little bit more broad, but for me at least, I mean, you know this, I like low back pain, dealt with that for a long time. And what I found really helped was glute, like specific targeted glute stuff, but like heavy glute stuff, not weird little prehab, rehab, bandy band glute stuff, like glute bridges and that sort of thing. So I guess my question is, and I'm asking you to make up a percentage here, but do you think on aggregate, if you sampled 100 tactical athletes, high speed killers, would the majority have like weak unattended to glutes because they just avoid that type of work, or do you think that the glutes typically are accounted for by just doing things?
Yeah, that would vary based upon who you asked. I'll say from my personal experience, the glute med, glute min, so those hip abductors are generally weak. The glute max is not always weak. We do a lot of uh, two-legged exercises in the sagittal plane, and that does require a lot of the glute max. But tactical athletes oftentimes will avoid the single leg exercises because there's not enough time, or it's uncomfortable, and it's not really the sexy exercises that you like doing. Like single leg RDLs on a landmine is nowhere near as fun as doing heavy deadlifts. So in regards to like a percentage of people, I can't give you a specific percentage, but I can give you a range in that a lot of the people that come to see me for running injuries and then potentially low back injuries, probably at least half of them could benefit from some sort of glute strengthening.
There you go. Love it.
Does that do it for low back pain? We got anything else?
I mean, you could do episodes and episodes on low back
Really?
pain. But for that, I think we're okay. Achilles.
I do want to say this. I do want
Oh,
to say this
oh,
though,
oh.
as like a parting comment. Um, that yes, rehab exercises can be boring for low back pain, but there are specific populations that just need to be able to load the back. That's where some of that easy McKenzie stuff, the McGill Big Three, play a huge role in helping fight against kinesiophobia and other things that may prevent them from otherwise being able to load, pain-free exercises that will help build back. Because those can be super powerful, and sometimes people do just need to take a step back from doing kind of the cool knees over toes type
Well,
stuff.
actually, so that does bring up a quick question because I want to say this is sort of the barbell medicine approach, which is to say that you hurt your back deadlifting. The recommendation in some cases would be to just not get rid of the movement, which a lot of people would do, but just take the load way down to where it's relatively pain-free and then build back up. Because the kinesiophobia piece you mentioned, I think, really is prevalent in the back
Hold
pain.
on. Before we continue, I think we've taken something for granted here because we all talk about it a lot. For the
Kinesiophobia?
audience, please define kinesiophobia.
Fear of movement, simple as that.
And probably in this case, fear of
Spe
specific movements
Specific
usually.
movement, yeah.
Mm-hmm.
Yeah.
Typically fear of the movement that caused the pain in the first place,
Or
or
since it's a little
perceived.
fuzzy, yeah, like the perceived cause of the injury, because it's not always like
Hmm.
the injury happened when you were doing a movement. That doesn't necessarily mean the movement was the cause of the injury. It's not always that simple,
Hmm.
et cetera, et
I
cetera.
think that's a powerful stimulus, though. I mean, you see people. I
Hmm.
was probably part of that where they might just perceive a movement they've never even done before to cause pain before they even do it, and ipso facto they experience pain. Man, we could go down a low back rabbit hole. Let's not. Let's jump to Achilles.
Sounds good.
Whatever you got, Achilles.
Yeah. What do you want to know?
The notes document doesn't say anything other than Achilles. That's why we're just saying the word
It
Achilles.
says Achilles issues.
I think the question is, I personally have not ever experienced Achilles tendonitis, but I know a bunch of people who have, and it seems like a really, really frustrating injury to even like let it relax. Like, cause like you're on your feet all the time. Like you can't not
Mhm.
aggravate it. So I'm just curious what the protocols are that seem to work for A, not aggravating it, and then B, making it better so you can get back to full activity.
So the frustrating aspect is common in tendons. Tendons don't have great blood supply compared to muscles and other parts of the body. So generally, they do take a little bit longer to heal. Ergo, they might take longer for the pain to go away as well. The best evidence that we have for treating Achilles tendinopathy, and you can take this and extrapolate on other tendons, so the research has not been done as extensively, is just basic tendon loading. There's one thing for people to take away is if you have Achilles pain, you have to load it. If you have complete rest or complete cessation of exercise, it's not going to get better. It's just going to be maintained in either a kind of a minimal to moderate pain state that may be limiting you from your full athletic potential or whatever kind of activities you're doing. So remember that tendon loading is important. One of the coolest things, though, that we learned specifically with the Achilles tendinopathy is that there is an ideal pain range that has been suggested, and it's 3 to 5 out of 10 pain. If you work in that range, that's your sweet spot. A little bit less than that, you may not be getting the stimulus that you need. And more than that, you're going to be doing too much harm for it to actually be able to repair. So 3 to 5 out of 10 pain, that's a good little baseline that I'll use for Achilles as well as other tendinopathy type things. And there's two different specific protocols that you can do. The first one is the classical one. It's from Alfredson et al. And this is for mid portion Achilles pain. So anywhere from 2 to 6 centimeters superior or north of your heel on the Achilles. It's not for the spot that inserts right onto the Achilles, but right in the middle of it where most people have it. And it's for chronic Achilles pain. This is for both protocols as well. So greater than 3 months, which generally is a lot of the patients. That's typically when they'll come in anyways. They won't always come in immediately after the injury. What you're doing is twice a day. You're doing 3 sets of 15 reps of bent knee and straight knee calf raises. And you're doing it every day. And you're working again in that 3 to 5 out of 10 pain range. Now, that's a good classic protocol. However, not a lot of people have that kind of time or the energy or the desire to be working their calves twice a day for that amount. The one that I'll generally give is the heavy slow resistance. And both of these have positive effects, equal positive effects in patients, but heavy slow resistance generally has better patient outcomes. My guess is because it's quicker. You do it 3 times a week for 12 weeks, and the focus is on eccentric and concentric contractions. You're doing 3 seconds lowering, 3 seconds raising, and you do it for 3 different exercises as well: the straight leg, seated calf raise, the bent knee, seated calf raise, and lastly, the standing calf raise. And generally, how you progress over the weeks is you decrease reps and you increase weight. I
Wait,
really like
can you
this
go through
though.
those three exercises again? I just got confused for a second.
Sure. You do a standing calf raise. You do the straight leg seated calf raise. So if you remember that thing from the YMCA growing up that all the kids would do and pedal their ankles. And then lastly is the normal or bent knee or normal seated calf raise
Okay.
exercise.
I was just confused about the concept of straight leg seated calf raises. Sorry.
I could definitely put something out too. This is pretty cool stuff.
Yeah.
I really like it though. It's similar to RPE and that you're using, or it's a form of autoregulation, but you're not using the weight. You're using pain as your stimulus or as your limiter rather. um, I think that's pretty much everything for the tendon loading. There are some other cool techniques that PTs can use. They may use is what the research says, including taping, dry needling, heel lifts. This is all according to the most recent practice guideline from 2024.
This wasn't in our notes, but since you
Were,
just mentioned taping, I kind of just want to ask you about KT tape in general.
were you doing calf raises while he was talking about calf raises?
Yeah, listeners
If I
can't
get
see our video, but Drew would have seen me like moving up and down a couple inches throughout
While
trying to
talking
answer
about
that
calf
question.
I'm
That's
raises.
trying to
because I
figure
was
out how you
doing,
did it though, because aren't you sitting?
No, he's
no, I'm
standing up.
standing. I stand to
Oh, okay.
podcast.
Now I see. Now I
I'm a
see.
standing desk hardliner. I do not sit.
Sitting is the new smoking. So they say. That is a good question. I'm curious about that. KT tape.
Before he answers, it was just like 4 days ago or something. I saw someone walk into the gym to do an Air Force physical fitness assessment. Now that I work around the Air Force, fitness culture in the Air Force is worse than it was in the Army. I had complaints about the Army. I think there were issues, but the Army's actually better off than a lot of places now that I've seen other places.
Hmm.
I think she had like 20 different pieces of KT tape all over her to get through the 1.5 mile run. Was that helping her out? I mean, forget about her and forget
Oh
about the
yeah.
run. But like, does KT tape work?
The Olympians would lead you to thinking that it does.
That would be healthy user bias, where we assume that one thing works because the collective of the things those people are doing works, but we would know better than that because that would be a fallacy.
Yes, we
I
are
think
smart.
there are some people that truly do benefit from the taping. There is research to suggest that it can be helpful. It is always sold to be more effective than it actually is, however.
Mm.
And personally, the patients I've used it on have asked me about it. I rarely do it. I'll never do it in isolation. I'll always do it with a form of exercise. And generally, the patient will have come to me to ask about it because they have a specific event or a specific task that they got to do and they want to have taping for it.
You want to know the best application for KT tape for the Olympic lifters out there is wrapping your thumbs for hook grips, just because it's
Oh,
flexible. Nothing to do with its original intended purpose, but yeah.
I think I used to be connected with a Kinesio tape guy on LinkedIn. Like he worked like for the company selling the tape, and he would always be posting about like different taping protocols and stuff. And
What are they claiming? That it just like keeps your fascia from moving around? Like, could you do the same with duct tape? Or is there something magical about the brand name bullshit?
I think the magic that's claimed to be out of kinesio tape is it's more elastic than duct tape or like leuko tape, which is the normal like athletic tape that people are using or a
So when
form of
people are
it.
KT taping their Achilles, are they like, are human beings honestly being convinced that they're taping their Achilles in place?
The theory is that you're providing a biomechanical advantage to the Achilles by doing it.
by slightly compressing your skin around it.
Yeah, like what's they're like the engineering physics of that make no sense.
So for Achilles, what you do is you tape the heel and then you'll
Sure.
cut several different strips and then put each strip. I'm moving my hand so people can see, but you put each strip along with the Achilles. You ride along the Achilles up into the calf. Basically, what that does is it pulls your heel into a slight bit of plantar flexion, which is what the Achilles action is. It plantar flexes the ankle.
But is the amount of force that that tape can provide even relevant to the amount of force that your Achilles is under?
I mean, I don't think so. I don't personally K tape myself, but placebo is powerful, and some people who ask for it truly do feel like it is beneficial. I don't want to completely knock it because it can work for certain individuals, and there are certain providers that swear by it. I'm just not one of them.
Okay.
I think you're gonna have some people in Instagram comments like pissed off about that.
Hmm.
Can't wait. Bring it
What do
on.
you think? Okay, gun to your head, would you rather cup somebody or KT tape somebody?
Depends on what they ask for.
Which one works
But
better?
if that's the dichotomy, I think I would have other problems I'd need to deal with.
Okay,
It seems like both fall into the broader category of it's
snake oil.
probably not bad for you. So if it makes you think you're getting better, we're going to use it to buy space to do the things that'll actually help.
Can be helpful. Again, it can be helpful for acute, like really pissed off injuries. Sometimes people just need a little bit of desensitization.
They should also pursue therapy for their heads.
All right. Next topic.
Patellar tendonitis, and maybe a commentary on just the idea of tendonitis in general, the itis. But patellar tendonitis. First of all, where is your patella?
It's your kneecap.
There we go. Okay, thank you. Now let's dive into patellar tendonitis. I knew that, by the way. It's just for the people.
Good, very good. Patellar tendon or the patellar ligament, as some will call it, is that band of tissue that is directly beneath or towards your heel or towards your foot under the patella. And sometimes what happens through overuse, generally, um, you can get a little bit of pain in that area, oftentimes found with jumping, running, um, endurance type training. You'll see it in these kind of populations. In regards to like the itis or the apathy, I don't know if we talked about this last time. I don't remember,
I
but
wasn't sure if we
itis,
did either, but I wanted to touch on it.
Before
yeah,
we do that, We did talk about that in the last episode, and I think it's worth revisiting. But now my brain is exploding for a second
You should
because
KT tape it. Tape it down.
so
There you go.
I have always referred to it as the patellar tendon. John just casually mentioned patellar ligament, which made me go back and think tendon versus ligament. Tendon is muscle to bone, ligament is bone to bone. The patellar tendon goes between your kneecap, which is bone, and your tibia, which is bone. Why is it called a tendon? It should be a ligament.
See, you're getting into etymology, and of that I have no interest. However, if you want to get specific, I think it could be either one. In that, yes, the patellar tendon does connect the patella to the tibia, but also the patellar tendon rests within the quadriceps, the patella rests within the quadriceps tendon.
So like it's
a
really an
sesamoid
extension
bone.
of the quad tendon.
Okay.
Okay.
Yes, to provide
Yeah.
a mechanical advantage.
Can you
Exactly.
explain? I'm derailing us even further, but it does have to do with the knee. And I remember this because I was in college, or no, I was out of college when this happened. But in 2013, they discovered the anterolateral ligament. Why did we not, like 2013, they discovered a new ligament in the knee? How many knees have we ripped apart over the hundreds of years that we've been doing this, and they just found something new? How does that happen?
I don't know. It's a great question.
That was so interesting to me. Anyway,
Yeah, I remember learning about that in school.
yeah, it says
Interesting.
the surgeons dissected 41 cadaver knees and found the ALL in all but one.
Hmm.
That's like finding a star. Like I would think that we would know all the muscles, but anyway, patellar tendonitis.
What do you want to know?
Did we
Do
on?
we need to first off revisit the definition? We can
Let's
do
do
that.
it. Yeah, itis and apathy.
And
Itis basically is inflammation. Apathy is generally like the pathology of the tendon, and then osis is more of that chronic degenerative tendon
So
array of diseases, if you will.
tendinosis would be long-term chronic. Tendonitis would be inflammation type.
well, you can have
And
chronic
then
itis.
Sure.
you
Osis
can.
is degenerative as opposed to inflammatory, and inflammatory is like a healing process versus.
But again, we're getting into semantics, which don't matter. In regards to treating the patellar tendon, similarly to the Achilles tendon, loading is essential. The one thing that I would say that changes with this is you should have a greater focus on training the glutes and then also the core in general. A little bit different, but patellofemoral pain syndrome. So pain directly
Mhm.
over the kneecap or under the kneecap. That's the patellofemoral pain syndrome. Great evidence suggests that we need to train both the knee and the hip to address that. This might be a little bit of a stretch, but in regards to treating patellar tendon, generally, I have more success for patients that also train the hips as well. And this is super easy. Make it fit naturally and organically in their workout program. Have them do some single leg stuff. Have them do some stuff in non-sagittal planes just to change it up. And oftentimes, that's more than enough to address the hips. In regards to patellar tendon, again, same rules apply. 3 to 5 out of 10 pain. Things that you can do for this, I'll give like a basic progression. One of the first things we'll start off with is a Spanish squat. A Spanish squat, basically what it does is it pulls your tibia forward with the use of a band while you're doing a squat. And generally what that can do is it can provide a little bit of relief over that painful area. This is often used again for that patellofemoral pain syndrome. It can be used for tendinopathy as well. What you want to eventually progress to is full squats, loaded squats, and then even things like decline squats or bicycle squats, which are similar, where you are where your heels are elevated and you're performing a squat that way. It just shifts your weight to be able to put a little bit extra load on the patellar tendon. And I talked about this earlier. You want to, if you can, I like having the guys be able to perform a full sissy squat, which is basically I'm trying to figure out how to describe this. You might just have to look it up before I do it bad justice here. Basically, it is a funny looking dance move where you get up on your toes, you move your knees forward so your hips are completely straight, your knees are fully bent, and then you come back up from that position. Again, I'm not
You get up
doing
on your toes and you like try and bring your knees to the floor while your torso is still
yeah,
upright. Yeah.
It's
exactly.
very
Yeah.
Easier
hard.
if
And
people look
there's
for a video.
It's very hard to do.
mhm. It is
In
very
terms,
hard to do. Use a dowel, use a rack to help keep your
Mhm.
balance. Anyways, all these things, this is taking the constraints that you have. Say you don't necessarily have the weights or the means to perform these exercises. Anyone can go and do a sissy squat with what they have. All they need is something to hold on to and some space. Um, Hopefully that helps with the patellar tendinopathy treatment. Um, Again, 3 to 5 out of 10 pain, focus on in there. Eventually, you're going to get to the point where you're not reaching that level of pain, so you can just load it continually. And then complete cessation of exercise or rest is always avoided.
So before we wrap up itises, osises, and apathies, I just wanted to ask a question because I've like experienced some good results with this idea in my head, but I honestly don't know whether it's true or not. I haven't been deep in the literature or anything. I've heard it suggested many times that a root cause for these things is muscular imbalances. Like you might get elbow tendonitis because you're doing too much bicep and not enough tricep, or you might get knee itis because you're doing too much quad and not enough hamstring, whatever it is. Is that true? Is that like a real contributing factor to all this stuff?
Specific diagnoses, I'm not sure. There is some literature for specific populations that would suggest that, yes, there is like a ratio, an ideal ratio to be met. And if you don't meet that ratio, then you will potentially develop imbalances that lead to injury. Those are generally specific populations and hard to generalize to the whole
That's fair.
population. More often, what we will find is general overuse. So, in regards to things like Achilles and patellar tendinopathy, people are this is a lot in like jumping, volleyball, hopping populations. We generally do jump. We favor one side when we jump. It's not always on the same side. So naturally, you're performing more stimulus than you can recover. That's what's going to happen to those like specific tissues. Again, that's super generalizable, not always the case, but generally what we will see if it's a true tendinopathy because of overuse.
Okay.
Easy.
Next up, IT band slash IT band syndrome. Again, I have certain interest here because it's another injury that I personally have experienced. What causes this kind of stuff? What do you do? Did the exercise I ended up doing where I was like wall sliding with like a knee and an elbow on the wall, and I'm acting it out, but none of the listeners can see it. Like that seemed
Nice.
to help, but maybe it was just taking a break
Yeah.
from running for a few weeks. I don't know.
Funny how that works.
Uh, yeah. IT band syndrome is pretty common. I think it's like 5 to 14% of all runners will deal with it at some point. Um, One of my first instructors, this has always stuck with me, and it always reminds me to check everything. In regards to IT band syndrome, it's sometimes true IT band syndrome, which generally resolves with just slowing down a little bit. But a lot of times you can have other structures that are referring pain to the area, potentially up in the glutes. So, we don't really have to go down this rabbit hole again, but dry needling up in the glute med, the glute min, and the TFL can provide some pretty significant relief distally at the IT band.
I was doing a lot of
Also,
glute
strength,
exercises during my
yeah,
trying to figure it out phase.
There you
Yeah.
go.
yeah, exactly. IT band, what it was previously thought was that IT band basically rubbing up against the tubercle within the knee. It's not really what the case is anymore. The current thought, which is I don't think it's proven, but the current theory is that the adipose tissue that sits underneath the IT band is uh, getting hypersensitized from overuse.
Hmm.
That's generally what they think is happening. So ways that you can address the pain. Again, this is probably more so is a little bit of deloading, but continuing to train is things you can do in the gym, single leg exercises, working in transverse plane, frontal plane type stuff. Um,
I
and
was
then
still able to
also,
do almost all lifting. I was still able to do stair climber. I just
mhm,
couldn't really run. Well, it depended on the volume of running I did before it started to get aggravated. And then
mhm,
downhill running in particular was the
mhm.
kind of the
Mm.
trigger.
Yeah, downhill running actually provides a greater shearing force than uphill running and then flat running to up in the glutes as well, right on that greater trochanter. So that could potentially cause some referred pain down into the IT band as well. But I think more important to think about it anatomically is that tensor fasciolata, that front muscle right on the, it's pretty much right next to your lateral most glute. It's just right in front of it. All those play a super important role in single leg activities, specifically with running. So generally with IT band, a lot of people come in like, I got pain at about a mile and a half of my run at this specific pace, or a little bit longer if I went a little bit slower. So what's the endurance? What's the capacity of those tissues to be able to withstand the forces you're putting on it at that speed, at that endurance? How can you train that to be more resilient?
Okay.
Should you foam roll your IT band and expect some sort of softening of the IT band? That's such a common one.
That is a hot topic. I hope maybe this is naive in me. I hope that people don't think when they're foam rolling their IT band, they're changing the fascial
They
structure.
do. They do. I'm just
Um,
going to cut you off. They do. That's
I
what they're
I
told.
was hoping that that common belief has changed. No, you cannot actually change the structure of your fascia from foam rolling, from body tempering, from any of that. That's absurd. You would literally have to go in and cut the fascia to change the structure if you wanted to change the actual structure of it. Either that or do something that is actually beneficial and do some weightlifting and load it, and thereby you can
Kelly
potentially
Starrett is
change.
so mad at you right now.
I know he's so mad. And I just started listening to Ready to Run too. Ooh, rough start, by the way. Rough start. Would not recommend. Um, Now you can certainly roll your IT band if you want. It's probably not going to do anything. If anything, it's going to do is it's going to provide some potential desensitization. If it's worked for you in the past, sure, give it a try. Why not? You're definitely not changing anything anatomically or structurally, though.
So body tempering, nothing.
Body tempering. You guys familiar with Donnie Thompson?
Aware.
First power lifter to break the 3,000 pound mark in competition.
That's just because
Since
I didn't turn my score in, but yeah.
Yeah, yeah, there you go. Yeah, he has this idea, and it's pretty cool. Some people really like it, as essentially super heavy metal foam rollers that you'll have a buddy like essentially bulldoze over painful muscles. And the thought is that that will, like, the thought or the selling thought is that breaks up fascial adhesions. It doesn't. It's just another tool at
Body tempering
desensitization.
being heavy foam rolling.
Pretty much. Yep.
So it's just a foam roller with a higher shipping cost,
Well, it's not foam.
effectively.
It's not foam.
Yeah, it's
Keep that in
like
mind.
metal.
Yeah. Yeah.
Um, this might be blurring lines, but I only ask because they've done these clinics for people, body tempering
Hmm.
clinics for people funded by the military. Anyway,
We should move on before
um,
Drew gets
I'm gonna get myself in
tied
trouble.
up in something.
How to build stronger, more durable hamstrings.
And
I'm gonna
add
answer
a
this
layer.
Romanian deadlifts.
I'm gonna add a layer to this question. And the layer I want to add, because I hear this term used a lot. I hear it used with knees. I hear it used with shoulders. And I definitely hear it used with hamstrings. There's just the whole bulletproofing concept. Um, I'm curious because like I had a period where I was a Nordic hamstring curl fanatic. Um, I can now, at this point, looking backwards, recognize that I was kind of cherry picking literature and it was pretty dumb.
You were a
Um,
big Nordstick guy. You had a face. I remember that.
I'm still I like them as an exercise, to be honest. I think they're
For
extremely
sure. Yes,
scalable. I think they
absolutely.
require minimal equipment. You can do them in a grassy field, so they're great for tactical populations. Um, I think they're good exercise, but I just don't. I went through a phase where I thought they were more important than they are. And
Hey, we've been there. It's okay.
bigger, broader lesson learned is that if anybody says one particular exercise is really bad or one particular exercise is really good, they're probably just experiencing some kind of personal attachment or hatred for that exercise. But back to the question, hamstring stuff. You hear a lot about pulled hamstrings, especially when people are like sprinting and haven't worked on sprinting before, whatever. I don't know if there's a question at the end of this. I'm just saying words, but I'm going to hand it over to you.
Sure. In regards to like stronger hamstrings, I'll defer to Drew as the subject matter expert and actual strength coach. But in regards to like an injury prevention standpoint, sprinting can happen. Like flat sprint specifically, we do see a lot of hamstring strains. Um, so generally, the advice that I'll give, and this is typical running advice too is when you're going to do your sprints, start with hill sprints. I know that sounds counterintuitive because hill sprints are suckier and harder, but generally what the body's going to do is it's going to prevent you from going to that top speed because of the change or because of the requirement on the lower extremities. So you're not really going to be able to reach that same amount of top speed that would otherwise cause your hamstring to pull. So start with hills, get a couple of weeks of that, and then you could start progressing to flat sprints. The other thing with the hamstrings, though, that we see a lot is first off, identify if it is the hamstring. Just because you might feel like you have a specific hamstring strain does not mean that it is the hamstring. You've got a lot of structures back there to include the sciatic nerve for one of them, which sits directly or approximates onto the hamstring muscle. Additionally, you have an adductor and the adductor magnus that functions as a hamstring part but sits on the interior of the leg. And then lastly, you can also have low back pain that radiates down to that area as well, that otherwise could all be masqueraded as, or some people may say it's hamstring pain, but it could be something else. So being able to identify specifically what that is can provide some relief too. It might not be that your hamstrings are tight. It could be that you have neural tension. It could be that it could be that the hamstrings don't want to fire at a specific level or at a specific speed. Kind of things like that. Those are the things that we try to address when people come to the clinic with hamstring problems.
Exercises. Sorry, Alex and I are fighting in the notes at the moment about
Listeners,
Zercher deadlifts.
brief aside for the
Ooh.
listeners, there's always a Google Doc.
We've talked about it. They know. Well, they should.
Well, not everybody listens to every episode. This will
That's
be
fair.
a little bit of a repeat for some people.
Welcome to the show.
But like it's Drew and I communicating in the doc, and then there's the guest, in this case John. John was actually provided the opportunity to be in the doc, but he had his own notes separately, so that's fine.
Thinks he's better than us.
Yeah, so we're just going back and forth in the doc.
Everything he has said tonight was generated by ChatGPT, guys.
That's right.
That's why he didn't want to join the doc.
Paid version.
Ooh.
We're just batting around exercises that
well,
we
you said
think are
Zercher deadlifts. I was like, you mean Zercher squats? No, you're deadlift. So are you?
Shout out Alec Blennis, does a lot of like
I was going to say, I know where this is coming from.
Yeah, and
Zercher squats really had like a moment in the sun there for a little bit on Instagram.
I've worked, and I can probably attribute deciding to put both of these in my programming to Alec, but both like Zercher RDLs and then single leg deadlifts. Both of those make regular appearances in my program now, and both of those I probably got hyped on because of Alex.
Zercher anything for folks that don't know is when you have your barbell in the crook of your elbows. So Zercher squat, you unrack it in your elbow crook. It's a weird phrase.
Super painful.
Yeah, Zercher squat, you unrack it in your elbows. Zercher deadlift, you get it off the floor with your elbows. Yeah.
Mm-hmm.
Which is fine. I mean, it definitely changes the lever action and like the physics of the movement. So you could make the case
and
for
like the amount of work your back has to do to stay upright and stuff. Yeah.
But I guess since John mentioned it, I'll put on my strength coach hat. Exercises for sure, Romanian deadlifts, and or straight leg deadlifts. I'm more partial to Romanian deadlifts, which for folks that don't know, the only difference really is an RDL starts at the top, a straight leg deadlift starts at the bottom.
I remember as I was getting my CSCS going down like a really annoying rabbit hole about the difference between RDLs and SLDLs.
That's really it. One starts.
The distinction has never mattered in my real life to date.
No.
But
well, I would say it matters only because when I prescribe them separately, there's two different reasons for it. I find that the RDL is, and I don't know, John may disagree, probably the safer of the two because you're starting neutral, standing up, and then you can lower it, basically slide it down the leg until you feel the stretch you're looking for, and then you come back up. Whereas with a straight leg deadlift, unless you have the requisite flexibility, you're kind of putting yourself into a pretty compromised position at the beginning.
That's fair. Most people are not going to get all the way to the floor.
Right. Exactly.
Okay. Fair enough.
For me, it's just a normal deadlift. And then I start my RDL.
I have done this with John, and
the first rep is the deadlift. The rest of the reps are already
So anyway, getting a little funkier with it, you could do like a deadlift from a deficit where you're standing on a plate, and obviously the higher you go on the plate, the more range of motion you'll need. But I find that really gets after the hamstrings and really the low back too. You mentioned Nordic hamstring curls. Those are great. You can do it with a partner or with a machine. The GHD machine has a lot of different options for hamstring strengthening stuff, but I like to load it a little bit heavier, which is kind of why I always fall back to the RDLs. Deadlifts for sure, but I think regular deadlifts probably for most people are more of a quad based thing than a hamstring thing, especially if you're talking about a hex bar, which I know we've hit on that before. But yeah, I guess for not wanting to give 1,000 different types of exercises, those would be the main ones that I would think of. Well, like kettlebell swings, actually. I would throw those in there too. Um,
Seated good mornings. Good mornings.
yeah, what are your thoughts on seated good mornings? I mean, standing good mornings for sure. I've heard mixed review. I like seated good mornings, but I've heard some people that I follow just sort of bash them. And
Those
maybe they're
went
just,
crazy on the internet for a while, and then it kind of got quiet again. I don't
well,
know.
because you had a bunch of thirst traps like sitting on a bench, propping their
Hmm.
butts up and leaning over real far, and guys just fell in love with it.
I mean,
I
I
think
need more
I think
followers
if
for the
you want
Instagram
to,
page, so
Get your tights
I
back on
think
and do
there,
some seated good mornings, man.
yeah, let's bring it back. I think there's a specific population that does have pain with loading,
Yeah.
um, and it is a challenging exercise for sure.
Hmm.
But start off with the unloaded, seated good morning, which do the legs straight. Your hamstrings are going to get a good stretch. You're going to have a little bit of neural tension based upon where you place your feet. And it could be just a good starting loading point for someone that may otherwise have pain with loading of the spine that you need them to be able to do that for
Hmm.
their job or whatever have you. I think it can be super effective. It just depends on the dosage.
Yeah, but having said that, actually, the sorest my hamstrings have ever been were after sprinting.
Mhm.
Like there's a hamstring strengthening exercise for you. It's dangerous, quote unquote, but it's good for your hamstrings. Um, okay, let's put that one to bed. Alex, I'm going to read this unless you want to take it.
go for it. I think at this point we're going away from asking about specific body parts and or specific injuries, pathologies, whatever, and we're gonna hit some like broader injury slash rehab phenomena before we wrap up the episode here.
Indeed. So this next one, from the onset of injury all the way to full return to duty or return to play, what is in and I guess in your experience, or if it is in the research, what is the biggest obstacle for patients slash athletes?
Biggest obstacle is this will require a paradigm shift, but it is the focus and reliance on complete rest. Louis Gifford said it best: disuse is catabolic. If you're not using your body, if you're not moving, you're going to cause further harm or you're going to prolong the recovery.
If you don't use it, you
Uh,
lose it.
exactly. There you go. The second thing, which I think this is important to take into account, is um, yellow flags or psychosocial factors that may impede upon someone's recovery. And we already touched on this a little bit, but for example, kinesiophobia, being afraid to move, or potentially being afraid of, there could be some form of secondary gain as well, trying to get compensation, trying to get out of certain things. Those can also be obstacles to full return to duty slash play. But on another sense, specifically in tactical populations, is it's difficult to manage stress well. And I'm not just talking about psychological stress. It's very difficult to manage all of the different uh, tasks that you have to do, as well as sleep, um, your general physical readiness, and everything you have going on with that, and then also what your job demands too.
One I want to throw out as we talk about it that I've become more acutely aware of over the last couple years working around both rehab professionals and performance professionals. I think there are times when patients kind of fall through the cracks of either one, like they've been given good stuff to do, but they don't know exactly how to do it. And so there like could be a handoff with a coach there that would help. Or two, they don't know when they've like this ties back to kinesiophobia, but they like developed fear of certain movements in the rehab process and they have no idea when to know when to stop being afraid of it. Again, that's a handoff thing between rehab professional and coach. all that's to say, I'm becoming a bigger and bigger advocate for like coaching professionals in clinic settings with like
Mhm.
more and more populations. Like I think even with civilian populations, I think you should see coaches in the clinics to help with those transitional parts
I
of
think
rehab.
I think those new we've talked about doing an episode on this, but the new clinics you're seeing pop up that are literally
Yeah.
in a gym. I
Yep.
think that is pretty cool. I hope that's the future of sports medicine.
Yeah.
Um,
I think that the people that fall through the cracks that you're talking about, and what I've learned and what I try and do is if I'm going to schedule a follow up or I'm going to say, tell a person that I want to see them again to make sure that they've progressed, I put it on the schedule. I don't just say, come back and see me in 3 weeks because they're never going to come back, especially if they are in leadership or they've got a lot going on in their life. The other thing too is if I want them to work with a strength coach, I'll walk them over to the strength coach or I'll tell the strength coach that he needs to reach out to them. If you miss that step, a lot of times, again, they're going to fall through the cracks and they may be at 85, 90% back to full duty. But to me, that personally is one of the things that I find to be essential in ensuring that that patient can get better.
As he says that, we should take a second, T's and P's, right? Thoughts and prayers. All the people that have access to rehab professionals and not coaches. Maybe you're in a military unit that doesn't have human performance. Maybe you're a civilian, whatever it is. I see this more and more frequently. Just the setting I currently work in, occasionally civilians wander through like, hey, my physical therapist told me I have to do load bearing exercise. I'm not sure what that means or what I'm supposed to do. Please help me. But I think for like outside of our little bubble of military human performance, most PTs don't have coaches to hand people off to. So most patients aren't going to get that warm handoff as part of their process. And I think this might be like we complain a lot here and say things aren't as good as they could be, but they're better than they could be too. And I think this is a space where the military might be a step ahead, where lessons learned from military human performance could apply in really significant ways to civilian healthcare.
this is like a curious question about just PTs in general. Like in the big bad world and maybe like a PT clinic, what is the protocol? Like if I'm there for a knee, something or another, I guess I come to you and do some exercises and then you just hope that I know how to train in a gym once we're done? Or how does that work?
I think it first off depends on what kind of clinic you're at. If
Like a clinic
if
that's
you're a
attached
set,
to a hospital.
oof, brutal. Those are pretty much just trying to churn through as many patients as possible. From my experience, physical therapist does the evaluation. That gets X amount of RVUs. And then every subsequent visit, they'll do a little nice manual therapy and then hand them off to a physical therapy aide to be able to do some exercise. Again, to just get as much revenue as possible because that's what brings in the money. Physical therapy does not make particularly a lot of money. That in that specific setting. I don't find that to be particularly helpful. Yeah, you can definitely get people to be better. And unfortunately, that is the reality in a lot of clinics because people need the help. But generally, the people that have really good results, I find that this is more in the cash based physical therapy world. This is more similar to kind of what the military can do, in that they can have a little bit more time. And again, this is not all clinics, but they can have a little bit more time with the patient. They can make it a little bit more personalized, and the treatments don't necessarily have to be focused only on generating uh, revenue. It can be focused on what matters to the patient, thereby being able to link them up with coaches and other clinicians. That's why you see a lot of these cash based clinics located in gyms,
Hmm,
kind of like you talked about earlier.
fair enough. Um, okay, this one will be fun. How much do warm-ups influence injury risk? And then as a follow-on, what does a good warm-up look like to you from a prehab standpoint?
For research, it's very difficult to standardize. However, there is some research to suggest that you will have reduced injuries in the upper extremities and lower extremities by about 36% if you have a thorough warm up. That's children and adolescents. I have not seen any specific warm up studies done on tactical populations or general populations. I'm sure there are some for specific sporting populations, but for the purpose of this, I didn't look into those. Um, so what does that leave us? What does a good warm up look like from a prehab standpoint? Um, so You can increase your blood flow. You can work on mobility pieces, stability, and then also get prep for your movements via explosive prep pretty quickly. You don't need to take the full 15 to 20 minutes, which is what some people are claiming that you need to take. Yes, that can be beneficial. However, I like combining different approaches. For example, when talking about mobility, right? Just because people say you need to work internal rotation for squatting doesn't mean you need to do it every time. Is that your limiter? Perhaps you've got great hip mobility. Maybe if you're trying to focus more on mobility, is it actually that, or is it maybe neural tension? Is it your thoracic spine? Or maybe it's not even mobility at all. Maybe you can, do a gentle mobility warm up, but if that's not your prime component or prime limiter at that time, you can move on to stability. And with stability, this is kind of where I like to combine efforts again. So instead of doing just basic, we'll say for the upper body, basic banded shoulder, internal rotation, external rotation, taking 5-10 minutes to warm up each muscle individually. What would it look like instead to do something like a bottoms up kettlebell windmill, where then you're working all the rotator cuff muscles and the core at the same time? Or maybe for the lower body, a lunge stance Palloff press, which is going to work your glutes, your knees, your ankles, and your core. And then I do think this is important, but plyometric activities.
Mm-hmm.
This is your jumping, your speed work. There is some research that will support that if you do this prior to your lifting, essentially you might be able to generate more power than you otherwise would not have been able to do had you not done it.
What are your thoughts on something? I know you've seen me do this, and anybody that's following any of our programming has seen this, but I'm a big fan of supersetting mobility stuff with lifts. Is there anything there, or do I just do it because it makes people feel good?
Again, there are certain mobility pieces that most people could benefit from. And for broad scale programming, I think it can be effective. Like hip external rotation is generally pretty limited. You may have a lot of thoracic extension and then shoulder flexion, limited range of motion for some specific sport requirements. So I think it could be beneficial, and it's certainly not taxing enough that it's going to affect your subsequent sets. However, in regards to, like, say I was to get personalized programming from you, I would probably say, hey, here's where my main limitations are. Can you fit these specific ones in as opposed to just like a general stretch in?
Hmm.
Which I know is not what you're doing, but I would probably ask for it to be more
For
specific. But
sure.
I do like the concept. I think that makes a lot of sense.
What about, I added a note here as we were talking, but I know cars, controlled articular rotations,
Mm-hmm.
PAILs, rails, these acronyms I think that are becoming more and more popular. What are your thoughts on those from a, I guess as a warm up? Because that's where I tend to see them the most. But what are those
Mm-hmm.
doing?
Basically, in regards to like a car or controlled articulation, uh, these work both aspects of mobility and stability. You're moving the joint through a specific range of motion that it's supposed to be able to move through, but in a controlled fashion. Nice, slow, easy. It's a pretty good warm up, a good burn. I know that some of the injury prevention programs have some hip cars in them, both in quadruped and in standing. But basically, you're just tag team and stability and mobility at the same time.
Hmm. Anything else on warm ups?
No, it
Listeners
looks
will
like
once
we
again
touched.
not be able to see it, but doing some hip cars
I was
on
wondering,
That's
you're
good.
like
Yeah.
standing
shifting
podcast
around.
Look like you're
station.
about to
Yeah,
talk. Yeah.
Yeah.
that's all.
How much, this is just a thought, but like, I guess the longer I've been doing this, I feel like warming up, really, it's just a matter of like, one, mentally getting to the right place. And then two, just getting legitimately warmer. You mentioned blood flow and all that, like just hopping on a bike or whatever and heating up the body to make it, I don't know, more pliable. And then three, another one for the mind, I suppose, is just getting exposed to whatever movements you're about to do and ramping the loading up so that literally it just feels lighter when you get to the. I say that because it seems very simple when you think of it that way versus you hear all the time, and I hear this a lot with like older tactical athletes specifically, but like, oh, I got to warm up for like 20, 30 minutes. I feel like that's more to do with just getting your mind right. And if you could find a way to shortcut the mental component of that, it's not so much that we're shortcutting like the physical bullshit that you're doing, but we're just like mentally getting you to where you are arriving at when you're doing it for half an hour. We're just doing it quicker. Does that make sense?
Oh yeah. No, I hear
I
that. I hear that a lot, and I always ask, like, do you want to do it for that long?
Yeah.
But generally, the people that have created that routine, they like it,
Yeah.
and it's
It's
something
to
they
get their
want to
head
stick with.
right. Yeah.
Exactly.
But do you think, I guess my question maybe is like, do you feel like they need it or that they want it?
Want it. I don't think they need it.
Okay.
I've been playing around with like warm up efficiency stuff. I do think warm
That's
ups
the
are a good
phrase.
place.
There's a phrase, warm up
Yeah,
efficiency. I like that.
because like anytime you spend on the warm up is time you're not spending on things that might be more productive.
Hmm.
I do think the warm up is a place where you can plug in some things that are just training, but happen to be training that's convenient to do at the beginning of your session.
Like plyometrics.
Yep.
Hmm.
Some speed work, things like that.
Hmm.
One I've started doing, I kind of stumbled my way into it because I like procrastinated and then I had to go somewhere like 40 minutes later. So I had to like somehow squeeze a workout and a shower into like a 40-minute window.
Did you work out in the shower?
No, I did not.
Oh,
But the warm up I did that day was hopped on a treadmill, did a minute at 5 miles per hour, a minute at 6, a minute at 7, and a minute at 8, and then back in a minute at 5. So it's you do a half mile running, part of like starting out pretty easy, getting to like decent pace running. And I've started plugging that in before like a lot of workouts because it's a good way to like semi rapidly ease into trying sort of hard. And it only takes a couple minutes, and you log an extra half mile of running that you might not have squeezed in that week or something.
There you go. Strava leaderboard.
I
hmm.
do the old PRT squat bender is a staple in my routine. Lateral lunges appear in my routine a lot.
Hmm.
I used to have like shoulder issues. I subluxed a shoulder back in college, not a major injury, but enough that it like annoyed me rock climbing sometimes. And I had like a very strict routine of things, and I still do it sometimes before I climb, but like face pulls, Bradford presses, a couple of those kinds of things. But I try and move through that stuff a lot faster now, just because that
Hmm.
also gets your heart rate up too.
I will say
Yeah.
actually, and this is shout out to Evan Pycon, so you can probably guess where this is going. But when I was really big on hooking Moxie monitors up to guys and tracking muscle oxygenation and all that kind of stuff, you could actually see the impact that a warm up would be having on somebody. And as an example, I had one of these on my quad when I was about to do some treadmill work, and somebody called me right before I set off. And so I ended up talking on the phone for about 15 minutes while I was walking on the treadmill. And the end result physiologically between that session and the exact same session a week later where I rushed the warm up was like the entire workout was different, even though the pace was the same, the prescription was the same. The physiological response was completely different, which was so cool. But I wouldn't necessarily advocate that for everybody because you would need a muscle oxygen monitor and you probably don't know what you're doing with those things. So there is something to be said about kind of priming yourself physiologically, I think. But I think we can put the warm up stuff to bed now, unless you guys have anything else.
Mm-mm.
That's all I got. I think we may have crossed the hour mark here at this point. I want to sneak in one last real question, then Drew might do his classic closer thingy. I don't know. You're not like a guest anymore. You're
We
part
don't,
of the
yeah, we
pod,
don't
so
really
you
need
might
to
not.
classically close with John.
Okay.
Well, actually,
Here,
you know what? Ask your question. I'll come up
there
with
you go.
something.
So my question, well, Drew figures out what he's doing, is you are a physical therapist, so understandably you're focused on the physical part of intervention in injuries and rehab and all that kind of stuff. I am curious about where you put your emphasis when we start talking about recovery strategies other than the physical stuff. Because there's obviously other layers like supplements for people who are recovering from an injury, changes to nutrition habits to either help with recovery or try to mitigate weight gain while your activity is reduced, any mental stuff, any sleep stuff, just like what we did talk a little bit about kinesiophobia, which certainly gets into the psychological part of all this, but just opening the floor for you to talk about non-physical recovery strategies.
Sure. Um, it's going to be blunt. Sleep 8 hours, eat protein, and if you need to, go talk to a therapist who's a non-physical therapist, a
A
mental
mental
therapist, if you
therapist.
will. Yeah, exactly. But I think and I know you said in the non-physical realm, but I do think that this has value specifically for the mental realm, is for managing weight and managing fitness while you're injured. You can train uninjured parts if you're cleared to do so, and that is as much as you can to still allow for recovery. Low impact cardio intervals are vital, specifically for lower extremity injuries. And you can be creative. You can get on the bike, you can get on the ski erg, the rower. Heck, you can even get on the upper body erg where it's just you're cycling your arms back and forth. That's what we'll do for like significant lower body injuries who can't put any weight through it. And then lastly, if for just like managing weight in general, if you have access to a dietitian, especially like all of our long-term injury guys, we send them straight to the dietitian once they get diagnosed because they're going to go from being able to burn so many calories per day to essentially minimal to none in regards to like the physical standpoint, especially if they're not taking advantage of some of that like low impact cardio and lifting the uninjured parts. So being able to use those resources if you have them. But I think really the things that limit people's recovery is not enough sleep, too much alcohol, too much nicotine. Unfortunately, that does include like Zyn. Zyn is not good for healing. And then obviously you
Neither are
talked about
energy
before.
drinks.
Yeah, neither energy drinks. And then the psychosocial component.
I'll layer one in there. John kind of said it, but I've seen this way too many times recently. Is people will have sometimes it's a major injury, but honestly, more often it's a moderate to even minor injury, and they use it as an excuse to just give up on fitness for a while, to like not do anything. And it doesn't take a lot of creativity to train pretty hard despite even major injuries. So I think there's a psychological component to that. Obviously, there's also a calorie burn component that ties into nutrition adjustments while you're injured. But just having people stay at least reasonably physically active, regardless of whatever the injury is.
Sure.
All right, closer. I think I've asked you this before. Perhaps it's a two-parter. What's something you've changed your mind on in the last 5 years, specific to physical therapy? And what's
Five
some,
years.
okay, let's say 3 years. What's something you've changed your mind on? And what's something you've doubled down on?
I think we touched on it today with the exercise not being a panacea for low back, even for the neck too. What we once thought was this is the answer. Exercise is the answer, and there's a lot of different, not necessarily expert opinion, but there is some expert opinion to suggest that exercise is the answer for these things. It's not. It's forced me to be more creative in treating low back pain and also more, I guess, personable and better understanding what is causing the patient to express these symptoms. Um, Super athletic populations, oftentimes exercise will do the trick. Maybe a couple little things of nice here and there, but generally exercise is super beneficial. But in the populations where there could be some secondary gain, or they might be avoiding something, that's where the art of the therapy aspect of being a physical therapist plays a role. What was the second part of the question? Double
Some,
down?
yeah, something you've doubled down on.
Double down. Okay. I might sound like a broken record, but I definitely have doubled down on the dry needling. I think it's super effective.
Oh, you
I've
think it's super
seen
effective?
I've seen really good results for dry needling, and
We
you can
already
get
knew
super
he was a
creative
dry
with
needling
it.
fanatic. Yeah,
Yeah,
Hmm.
that's not new.
Hmm.
that's a good point.
I don't think it's panacea. I will say that,
You may want to
but
just explain really quick what panacea means because you keep
a
throwing it out.
cure-all.
There you
Sorry.
go.
Yes,
No, I
it's
know not a lot of
cure-all.
people know Latin, so I figured you might as well
Mhm.
throw that out there.
But we have, and the reason I say I've doubled down is there's a lot of people with just myofascial pain, muscle fascia pain. Pain hurts right here because of this. Why? Um, and maybe there's a weakness, but there's not really validated measures that are going to allow me to figure that out. with at least with the capabilities that I have. But what I will say is, somebody comes in, this hurts right here. If you stick a needle in it properly, correctly, and safely, and it gets better, then, they're going to come back and thank you for it. And then generally you'll have pretty good patient results with that.
Fair enough. Okay, let's close it down. I will say we have talked about doing more of these in the future. So for people that do have questions that come up specific to injuries, send them in. We'll compile them. We'll have more of these conversations. Like we mentioned, John's getting a microphone, so he'll certainly sound better next time we have him on.
And shamelessly, before we
Yeah,
close,
for sure. Plug it.
if you're dealing with a particular one of these, we do have a whole set of programs designed by John on the website for like injury prevention and kind of generic rehab stuff. You get to choose between a blueprint, which adds on to whatever training you're already doing, or a master plan, which serves as your whole program.
Boom. Okay, gentlemen, a pleasure. Goodbye.
Thanks again.
Hey, Alex, let's cover our ass real quick.
Oh, great idea, Drew. All right, guys. The views and opinions expressed in this program are those of the speakers and do not necessarily reflect the views or positions of any entities they represent.
Thanks for tuning into this week's episode. Before you go, please rate and review the pod on the listening platform of your choice. You can also visit us on our website at www.mopsinmos.com. That's mops, the letter N, mos.com. You can check out the library of podcast episodes, our latest blog entries, any helpful resources, and also sign up for our newsletter.
Drew nailed it. Just to underline a couple of things, the podcast entries have in-depth show notes on the website. So if you missed anything or you want to read any of the research we talk about, it is all there. You can, at the bottom of the website, sign up with your email and receive future updates from us. The blog posts go a little bit more in depth in kind of written form on a couple of topics we get questions about all the time. But most importantly, I just want to ask all you guys, our best way the word gets out is absolutely word of mouth. So tell your friends, tell the people you work with, anybody you think would find it useful. Thanks for spreading the word.
If you have any questions or comments, feel free to shoot us an email at either Drew or Alex at mopsinmos.com.
Or there's a contact form on the website.
Thank you.